Hello everybody. In this recorded lecture, I'm going to be discussing anxiety-related disorders. Anxiety-related disorders include anxiety disorders, obsessive-compulsive disorders, trauma and stressor-related disorders, somatic symptom disorders, and dissociative disorders. As you will learn while we go through this lecture, all of these disorders are rooted in stress, anxiety, or fear. And while you may have heard of some of these disorders before, it is very important as nurses that we understand the dynamics of these disorders, how they affect individuals, and how they manifest as mental health disorders. Remember, for these to be a mental health disorder, they need to be causing impairment in social and/or occupational functioning. We all experience anxiety. However, we do not all have an anxiety-related disorder, so it's very important to be able to differentiate between the anxieties of day-to-day life and anxiety-related disorders. Furthermore, the better you understand these disorders, the better you can provide appropriate nursing care and interventions. Because regardless of where you work in nursing, you will be interacting with patients that have anxiety-related disorders. So let's get started. As always, I want you to use the objectives to guide your studying for the exam. Remember, I am not preparing you to be psychiatric nurses. I am preparing you to be nurse generalists who are prepared to care for a patient working on any unit who may present to you with an anxiety-related disorder. So as we go through this lecture, there's a lot of terminology. Try not to get bogged down into the details, but focus on the big picture items, and I will highlight those as we go through this lecture. Before we head into the specific disorders, I want to start with some terminology, as there are terms that I will use throughout the lecture that some of you may be familiar with or may have heard about before. However, these are terms that are often misunderstood, and I want to ensure you know and can differentiate between the true meanings of these terms. Depersonalization is a feeling of unreality or detachment from oneself as a person. Derealization is a feeling of detachment or unfamiliarity with one's surroundings. Dissociation is removal from the conscious awareness of painful feelings, memories, thoughts, or aspects of one's identity. Dissociation is a defense mechanism that protects an individual from the emotional pain of experiences, conflicts, or trauma. Dissociative amnesia is the inability to recall important personal information that is usually of a traumatic nature. Individuals may experience selective amnesia, the inability to recall specific aspects of an event, or generalized amnesia, a complete loss of memory related to their life history surrounding a traumatic event. As I alluded to, the first set of disorders that we are going to talk about are anxiety-related disorders. If you think back to the very beginning of the semester, one of the first lectures we did was a lecture on stress and the stress response. Anxiety is this manifestation of the stress response. If you think back to Steele's stress adaptation model, the alarm phase, that fight or flight activation response, if you think back to the Lazarus model of stress and the interactions of the cognition, the sympathetic nervous system, and the neuroendocrine system, these are the stress responses causing a subjective experience, what the patient is feeling, detected by those objective behaviors that we are seeing. In other words, the cardinal manifestation of the stress response is anxiety. So anxiety in itself can be a normal response to stress. Remember, it becomes a disorder when it is impairing your social and/or occupational functioning. Before we go into specific anxiety-related disorders, I want to pause for a minute and refresh you on anxiety's biological cascade, or the stress response. This slide should look very similar to one of the slides from our lecture on stress. If reviewing this information seems foreign to you, I encourage you to go back and review your notes for that lecture. So, the stress response is predictable and it has a physiological nature and foundation. When somebody becomes stressed, when a threat is perceived, there are two systems that are activated. The sympathetic adrenal medullary, or the SAM, is activated and norepinephrine is released. At the same time, the hypothalamic pituitary adrenal axis, the HPA, is activated. Epinephrine and cortisol are released. Remember, epinephrine and norepinephrine, as well as cortisol, are our fight or flight neurotransmitters. Our body is preparing to respond to whatever this trigger is. Therefore, our insulin resistance is going to increase. We're going to develop mild inflammation and a thrombotic state. This is preparing us for injuries that may occur if we have to fight the bear or run from the bear. At the same time as this is occurring, our amygdala, our hippocampus, which are located in the limbic system of our brain, that emotional cortex, they are using that cortisol and that norepinephrine to help retrieve emotional memories. How did you respond to this type of event in the past? Is this bear just a mild little bear and you are strong and you are going to fight him off? Or did you barely survive the bear the last time? And these emotional memories either help you deal with the stress or the anxiety, or in the case of anxiety-related disorders, these memories that come down become fearful and traumatic, bringing back horrible past experiences or near misses of past experiences, which leads us into anxiety-related disorders. So what are anxiety-related disorders? What is anxiety? Anxiety has been described as an uncomfortable feeling of apprehension or dread that occurs in response to stimuli that is either internal within your body or external happening around you. This feeling of response of dread or fear is usually in the absence of an actual threat, or the response is disproportionate to the nature of the threat. So the threat may be something that is very mild. However, the person has an extreme, intense fear for how they are responding to that threat. A good example of this would be my recent traveling on an airplane. Flying gives me extreme anxiety. Dante is a safety engineer. He has explained to me many times how much safer it is for me to fly than to get in my Jeep and drive somewhere. I have a mathematics background. I have read the statistics on this. I know that flying is inherently safer than traveling in a car. However, when I know that I am going to be flying, I have high levels of fear, I have high levels of worry, I have high levels of nervousness. When I am spending that 2 hours waiting for the flight, I am not one of those people who is sitting there being productive. I am pacing, I am sweating, I am moving around. I probably went to the bathroom in those 2 hours no less than 7 times because I had a fear and a fear response that was disproportionate to the actual threat of getting on the airplane. In general, when we talk about anxiety, there are 4 levels of anxiety that you need to be aware of as the nurse so that you can evaluate, assess your patient, and determine how severe their anxiety is, regardless of what type of anxiety disorder they have. Because remember, all of these anxiety disorders have this underlying component of excessive fear and behavioral disturbances. Mild anxiety is anxiety that may not be causing a disorder. If somebody has mild anxiety, they have a heightened degree of alertness. They're very aware of their surroundings. Sometimes people describe this feeling as the butterflies in their stomach. Think of the feeling that you get before you start an exam, before you start a sporting event, especially when I ran cross country while I was waiting for the gun to go off to start that race. I could feel that I had that alertness. I was ready to hear that gun go off to start running. I had the little bit of butterflies in my stomach as I was jockeying for my position to start the race. Mild anxiety. Moderate anxiety is when we start to see symptoms that are affecting your functioning. Patients become diaphoretic. Their skin is cool and clammy. You feel your heart starting to pound. You feel your blood pressure starting to increase. Mild anxiety may be prepping you that you have that excitement to start and go. Moderate anxiety, this has now increased and is the symptoms we usually think of when we think of anxiety. How you respond as an individual to those symptoms in your body, are you able to regulate them and bring back homeostasis, or are they going to get worse? Is the stress response going to continue? If that stress response pushes forward, that knocks the patient into severe anxiety. Severe anxiety is an intensification of the symptoms of moderate anxiety. Not only is your heart pounding, is your blood pressure increasing, are you sweating and cool and clammy, but now you may start hyperventilating, which is going to cause you to become dizzy. You may become nauseous. You may actually vomit. You may start to have an inability to think, to hear, to focus. The anxiety is starting to overwhelm you. And at this point, if your body is not able to regulate and come back to homeostasis, you go all the way into what is considered panic. Panic is a very severe form of anxiety. You have the symptoms of the 3rd level of severe, plus an inability to function. There are high levels of dread, terror, fear that can literally physically paralyze you. You can't respond to the events going on around you. And you may start to develop some sense of disorganization of your personality. Your response in that fight or flight, you are now beyond fight, flight, you are in freeze. Think of, if you're driving down the road, that deer in the headlights, when that deer sees you coming driving and it just stops in the middle of the road and you're thinking, why isn't it running? It is in full-blown panic mode. It is in dread, it is in terror, and it physically cannot move. That can happen to humans as well. The first anxiety disorder we are going to discuss is generalized anxiety disorder, or GAD. This is often the disorder that people are referring to when they say they have an anxiety disorder. GAD is characterized by excessive or unreasonable worry or apprehension. And this worry is not just worry related to one isolated event or occurrence, but rather individuals with GAD have chronic, excessive, or unreasonable worry. And their worry is often not related to just an event like I described with going on the airplane, but related to everyday events and occurrences, such as job responsibilities, their health, the care and safety of their family, their finances. Therefore, for an individual to be diagnosed with GAD, they need to have symptoms that are persistent and ongoing for at least 6 months, as well as impairing social and occupational functioning. Worry is the key indicator that I want you to think about when you think about GAD, because for individuals with GAD, worry becomes a habitual coping mechanism, because individuals with GAD develop their belief that if they worry about something ahead of time, that is a way of preparing, thinking about what might happen, and if they worry about it and they're prepared for it, they can prevent this negative occurrence. And that's not to say that preparation is a bad thing, but when that preparation gets to the point that it is consuming your everyday thoughts, feelings, actions, it's impairing your functioning. So, as a result of this overemphasis on worry, individuals with GAD often have symptoms of decreased concentration and memory problems. They can't focus on anything but that worry. You will also generally notice other symptoms such as restlessness, fatigue, trouble concentrating, irritability, muscle tension, trouble sleeping, or insomnia. The etiology of GAD is not entirely known. Biological theorists recognize that neurotransmitters appear to play a role in GAD, with low serotonin being the primary neurotransmitter associated with this disorder. Psychosocial theories also consider the role that childhood and adult trauma can play in the development of GAD. The theory is that individuals who have experienced severe trauma use worry as a coping mechanism to try to help them regulate these painful emotional experiences, especially the experience of repeated shame. And so you will often find that a characteristic of individuals with a diagnosis of GAD is that they are extremely apologetic. They apologize for everything, even events they have no control over. I am very open. I have a diagnosis of GAD. I do this extreme apology. And one of the examples is I apologized to Dante the other day that it was raining. I have no control over the rain. He was frustrated that it was raining because there were things he wanted to do outside. He wasn't taking the frustration out on me. But instead of having a therapeutic response of saying something like, that must be really frustrating, I know you had a lot of plans today and this unexpected rain impacted it, my natural inclination response to that is to apologize for the rain. I have no control over the rain. However, an individual with generalized anxiety disorder is going to apologize for it to try to take away some of that shame, to take that responsibility on. The next set of disorders we're going to discuss is panic disorder. Panic is an extreme, overwhelming form of anxiety experienced as a response to a real or perceived threat. Remember, I discussed panic a few slides back as the fourth stage of anxiety. You will often hear panic referred to as a panic attack, and that description makes sense because when an individual experiences a panic episode, they go through the stages and phases of anxiety very rapidly. A panic attack sends someone from mild anxiety, level 1, to level 4 panic, peaking at about 10 minutes. These individuals often describe their feeling as an abrupt surge of intense fear and discomfort. Panic can be completely unexpected or situationally bound to known triggers. Individuals often describe the fear and discomfort associating a panic attack as the feeling of a sense of losing control, feelings of going crazy, feeling like they are having a heart attack, feeling like they are dying. Working in the emergency room, it is not uncommon for us to see patients come in complaining of symptoms that they believe to be a heart attack. And after a thorough evaluation, both cardiac and psychosocial, we are able to determine that the patient had a panic attack. Panic disorder occurs when an individual experiences recurrent attacks of panic and then becomes worried that these attacks are going to lead to more attacks in the future, thus the impairment in social and occupational functioning. Individuals with panic disorder often avoid places or situations where a panic attack has previously occurred or where they feel like one might occur. Like with most psychiatric disorders, there are multiple theories regarding the etiology of panic disorder. Biological theories tend to focus on a chemical imbalance between the neurotransmitters of GABA, serotonin, and norepinephrine. And the idea is that these neurotransmitters cause dysregulation of the sympathetic nervous system. Biological theorists also recognize there is a genetic link to panic disorder, as individuals with an immediate family member who has a diagnosis of panic disorder have a 40% increased risk of developing the disorder themselves. Remember, I am not going to ask you about these specific numbers on an exam. I'm giving this to you as a point of reference. Psychosocial theorists also consider the role that your environment and upbringing, such as adverse childhood experiences or the ACEs, can play in predisposing someone to panic disorder. In general, researchers agree that panic disorder is the result of many factors at play, specifically 3 big factors: the sympathetic nervous system, the adrenals, and the cognitive processing system. Together, these symptoms can create a trigger for panic. The sympathetic nervous system is your fight or flight response. We discussed that earlier. The adrenals have the adrenal medullary, again contributing to that increase in anxiety. And cognitive functioning has to do with your thinking and these consistent what-if thoughts. And as these 3 factors work together to not only change your chemical imbalance, but also play off previous experiences and thoughts, the symptoms of panic begin to develop and can become chronic for individuals with a panic disorder. We are now going to shift our focus to phobias. Phobias are anxiety disorders characterized by an excessive fear or anxiety about specific objects or situations. Individuals with a phobia disorder often experience apprehension, anxiety, or feelings of helplessness when confronted with the phobic situation or feared object. This fear is out of proportion to any actual danger posed by the object or the situation. Specific phobias are amongst the most common psychiatric disorders in children and adolescents, and thus these disorders tend to develop early in life. They usually develop following a traumatic event or observing others going through a traumatic event. For example, my father lived through the Johnstown flood in 1977, and as a result, he is petrified to drive over bridges and goes out of his way to avoid driving over any bridges. While phobias can be to many different objects or situations, we're going to focus on 2 specific phobias. The first being agoraphobia. Agoraphobia is a specific phobia characterized by marked fear or anxiety triggered by exposure to public places or situations such as using public transportation, being in a crowd, or being outside of the home alone. Underlying agoraphobia is usually a fear that a panic attack will occur and the individual will not be able to escape the situation or location. As with other phobias, this fear is out of proportion to any actual danger that is posed by the situation and is often tied back to a traumatic event. The other specific phobia that I want to discuss is social phobia, which you will often see referred to as social anxiety disorder. This phobia is characterized by a marked fear or anxiety of being scrutinized in social situations. Individuals with social phobia have a persistent fear that they are going to be judged as weak, as crazy, as stupid, boring, intimidating, or unlikable by others. The etiology underlying social phobia is classical conditioning, and that this social phobia is a response to direct negative experiences such as being bullied, humiliated, or ostracized. Other psychosocial factors that impact the etiology can be how a child was parented, as well as traumatic life events and adverse traumatic social experiences. Considering the impact of bullying and humiliation, which we often hear about in schools, it is not surprising that social phobia has a very early age of onset, and the average median age of onset for social phobia is about 13 years. Remember, though, this is a chronic disease and disorder that is going to proceed with the individual throughout their lifespan, impairing their social and or occupational functioning. Before we move on to our next category of disorders, I want to take a moment and pause to compare and contrast anxiety versus depression, because these two disorders do tend to be comorbidities of each other, but they have distinguishing characteristics. The manifestations are different. In anxiety, the affect is often fear or dread. In depression, the affect is more an affect of sadness, despair, helplessness, hopelessness. While both anxiety and depression have insomnia as a distinguishing feature, the insomnia is different in how it presents. For individuals with anxiety, they tend to have trouble falling asleep. Individuals with depression have early morning wakening followed by difficulty falling back to sleep. With motor activity, individuals with anxiety tend to have psychomotor agitation. They are restless. Think of what you picture with anxious, the jitteriness, the movement, can't hold still. Depression, on the other hand, has that retarded motor activity, that general slowing. The negative thoughts and feelings with anxiety are limited to specific areas, objects, or situations. The negativity related to depression is more globally bound. So I would be able to distinguish between the manifestations of anxiety and depression. We are now going to move on to obsessive compulsive disorders. Obsessive compulsive disorders share an underlying concept of neutralizing recurrent thoughts, ideas, or impulses through the use of rituals or repetitive behaviors. Obsessive compulsive disorders include OCD, which is obsessive compulsive disorder, as well as body dysmorphic disorder, hoarding, trichotillomania, and excoriation disorders. For the scope of this course, we are going to focus on obsessive compulsive disorder, as it is the disorder from this category that you are most likely going to see in practice. Obsessive compulsive disorder is characterized by the presence of obsessions, compulsions, or both. Obsessions are repetitive, persistent, and uncontrollable thoughts, ideas, impulses, or images that are experienced as intrusive and unwanted. Compulsions are an individual's attempt to neutralize the obsession with another thought or action. Compulsions, which may be referred to as rituals, are thus repetitive behaviors or mental acts that an individual feels driven to perform. These often include things such as repetitive washing of hands, returning and checking that the stove is turned off, checking that the door is locked, checking that you fed the dog, things such as repetitively counting and repeating words. The compulsive act is aimed at reducing the anxiety triggered by the obsession. However, the compulsion is often not connected in a realistic way to the feared thought. Psychosocial theories underlying obsessive-compulsive disorder emphasize the importance of how individuals appraise or misinterpret feared situations. Often those with obsessive-compulsive disorder experience catastrophic beliefs that having a thought increases the probability of it becoming a reality, which leads to the emotional stress and compulsive behavior. An important distinguishing feature of obsessive-compulsive disorder is that the obsessions or compulsions are so severe that they will significantly interfere with a normal routine and become so time-consuming that they interfere with social and/or occupational functioning. I want to be sure to clarify that having an obsession or compulsion on its own does not necessarily indicate a disorder. In this society of high achieving and fast pace, many of us can become obsessive or compulsive at times. However, we do not let this rule our lives. Remember, there is a difference between characteristics and traits and a disorder. In our lecture on personality disorders, I'm going to talk about obsessive-compulsive personality disorder. For the exam, you should be able to distinguish between obsessive-compulsive disorder and obsessive-compulsive personality disorder. I would also highly encourage you to know and understand the difference between an obsession and a compulsion. The next category of disorders we're going to talk about are trauma and stress-related disorders. These disorders develop after exposure to a clearly identifiable traumatic event, an event that threatens the self, threatens others, threatens resources, or threatens an individual's sense of control or hope. Each one of our psychological responses to stress is variable after a traumatic event. Events that overwhelm an individual's usual coping strategies can lead to trauma and stress-related disorders, such as post-traumatic stress disorder, acute stress disorder, and adjustment disorder, which we will talk about on the upcoming slides. These disorders are adaptive processes designed to help our bodies to respond quickly when a traumatic circumstance occurs. They often arise from exposure to multiple types of traumatic stressors that are either sustained or repeated. Thus, chronic trauma, especially in childhood, leads to the deterioration of emotional and relational capacities, which causes a loss in your healthy psychosocial development. Think of Erikson's stages of development. Therefore, how an individual reacts and responds to trauma depends very heavily on their psychological factors as well as their prior life experiences. We will go over the 3 disorders I mentioned: acute stress disorder, post-traumatic stress disorder, and adjustment disorder now. We will also do an entire lecture on response to violence and trauma later on in the semester. Both acute stress disorder and post-traumatic stress disorder are characterized by an intense emotional reaction, such as fear, helplessness, or terror after exposure to a traumatic event. It is important to understand that exposure to a traumatic event can and does include witnessing an event as it occurred to others, or learning that a traumatic event has occurred to a close family member or friend. The distinguishing factor between acute stress disorder and post-traumatic stress disorder is the onset and duration of symptoms. A diagnosis of acute stress disorder is made when an individual has dissociative symptoms during or immediately after a distressing event. This is generally classified as symptoms that persist less than 1 month following the event. Dissociative symptoms include symptoms such as amnesia, depersonalization, derealization, decreased awareness of one's surroundings, a general feeling of numbness, detachment, a lack of an emotional response, or flashbacks. The diagnosis of post-traumatic stress disorder is made when these same characteristics and symptoms progress 1 month or more after the trauma. Some of the other major characteristics of acute stress disorder and post-traumatic stress disorder include re-experiencing the traumatic event in forms such as intrusive and unwanted memories, upsetting dreams or nightmares, or even the flashbacks that I mentioned before, which are sudden feelings as if the event is recurring in front of them. Because of these characteristics, individuals with post-traumatic stress disorder are often at risk for developing other psychiatric disorders, such as depression, substance use, or suicidal ideations. Sadly, it is very common for post-traumatic stress disorder to go unrecognized for years. There are many reasons post-traumatic stress disorder goes unrecognized, but beyond the general reasons we discussed, such as stigma, another reason is that many individuals do not perceive their symptoms are indicative of post-traumatic stress disorder because they were not victims of a major catastrophe, such as a devastating natural disaster or war. Therefore, they may not report these symptoms as being anything worthy of concern. As a nurse, you need to remember that everybody's symptoms are real to them, and everybody experiences and processes traumatic events individually. The structure of your brain, your neurotransmitters, and your autonomic nervous system are all involved in how you, as an individual, are going to perceive and process trauma. During exposure to a trauma, individuals are generally going to experience the stress response. Their heart rate is going to increase, their cortisol levels are going to increase, and their adrenal activity is going to increase. Individuals who have post-traumatic stress disorder have been shown via brain scans that when traumatic events occur, they also have the dysregulation of their prefrontal cortex and dysregulation of the amygdala at play here, which causes excitatory reactions and inhibitory responses indicative of post-traumatic stress disorder. The inhibitory responses can be referred to as desensitization, and this is a process where individuals adapt to repeated trauma by suppressing their emotional distress. And often this suppression is experienced as depression and emotional numbing. While the individual initially appears numb, their body is actually hyper-aroused in response to this repeated stress or trigger, similar to the trigger that caused the post-traumatic stress disorder, which can lead to aggression, impulsivity, and overreactions to situations that are benign, ambiguous, or otherwise may be considered mild. You often see this play out when soldiers come back from war and they hear a loud sound and they respond as if it is a gunshot or a bomb. They may at baseline have this desensitization, this depression and numbing, but then something triggers a hyperarousal response. The other trauma and stress-related disorder that I briefly want to touch on is adjustment disorder, because this is a disorder that we are seeing more frequently diagnosed in the inpatient setting. Adjustment disorder is characterized by a marked emotional distress resulting from an identifiable stressful life event. Often these are events such as divorce, a painful illness, a job loss, or a natural disaster. Symptoms develop within 3 months of the initiation of the stressor, but the reaction is not severe enough to fit the criteria for post-traumatic stress disorder. The reaction does not include those severe dissociative symptoms. However, the symptoms and reactions are considered to be out of proportion to the severity or intensity of the stressor. This acute reaction does interfere with social and/or occupational functioning, making it a disorder, but it is isolated in that it lasts no longer than 6 months after the stressor and its consequences have ended. Notice I said stressor and consequences. If the stressor is a chronic stressor, such as the diagnosis of a chronic disease, the consequences may persist beyond 6 months. Thus, symptoms will progress along with the consequences. Say the chronic disease is then cured or eradicated. Within 6 months then, the symptoms will resolve. So very important that you understand this is a limited disorder, and the disorder resolves when the source of the distress resolves. The next category of disorders we are going to discuss is somatic symptom disorders. These are disorders where patients have physical symptoms from which there is no known organic cause or physiological mechanism that can be diagnosed. Somatic disorders share a common feature of distressing somatic symptoms associated with abnormal thoughts, feelings, and behaviors in response to these symptoms. Individuals with somatic symptoms are usually encountered in primary care or non-psychiatric settings. Therefore, for the sake of this course, we will focus on conversion disorder, which is one of the most common somatic disorders that you may experience inside or outside of a psychiatric setting. Conversion disorder, which you may also see referred to as functional neurologic symptom disorder, is a somatic disorder with the major feature being a deficit or alteration in voluntary motor or sensory function that mimics a neurologic or medical condition. Conversion disorder is typically associated with psychological or physical stress or trauma, and individuals with this order will experience spontaneous attacks of severe physical disability, despite a lack of medical evidence underlying the cause or etiology of the symptoms. The symptoms that they experience may be transient or persistent. They may be motor symptoms or sensory symptoms. Motor symptoms include paralysis, tremors, gait abnormalities, abnormal limb posturing, often symptoms that appear similar to stroke-like symptoms. Sensory symptoms can include symptoms such as skin sensation changes, development of temporary blindness, temporary deafness, and often symptoms that we associate with seizure activity or, again, mimicking strokes. Patients may also experience dissociative symptoms such as personalization, derealization, and amnesia during an attack. Patients also generally display an attitude of what we call labile indifference for their symptoms, meaning patients express little concern or worry when these symptoms occur. This can often be interpreted by healthcare providers as the fact that the patient is minimizing their illness. And these patients can be challenging cases because they often do not seek treatment related to that attitude of labile indifference. Next, we will move on to dissociative disorders. Dissociative disorders are characterized by a disruption in consciousness, memory, identity, emotion, perception, body representation, motor control, and behavior. The major features of dissociative disorders are depersonalization, derealization, amnesia, numbing, and flashbacks. And you should recall that we discussed some of these terms at the beginning of this lecture. If you don't recall these terms, I encourage you to pause the lecture and go back to the beginning and review them. Dissociative disorders are frequently exhibited in the aftermath of trauma and are closely related to trauma and stress-related disorders. If you recall from our discussion of acute stress disorder and post-traumatic stress disorder, both of these disorders contain dissociative symptoms, the amnesia, the flashbacks, and the depersonalization. For this course and the depth and level we need to go into at an introductory level course to psychiatric nursing, we will discuss dissociative identity disorder. Dissociative identity disorder is a defense against extreme anxiety that is aroused in highly painful and emotionally traumatic situations. This disorder is most often seen in survivors of severe childhood sexual abuse. Dissociative identity disorder is characterized by the existence of two or more distinct identities or personality states, as well as recurrent episodes of amnesia. Dissociative identity disorder usually occurs when a child is so full of pain caused by trauma that the child can no longer integrate this painful experiences and thus splits off the painful events to allow themselves to survive the trauma. However, this splitting or development of alternative personalities, often referred to as alters, results in an impaired personality with disconnected parts. These alters typically manifest as if another person has taken control of the child's body, such that the child begins speaking or acting in a distinctly different manner. Each alter has its own name, its own behavior traits, its own memories, emotional characteristics, and social relations. In some cultures, dissociative identity disorder may be described as being possessed, such as possessed by a spirit, by a ghost, or by a demon. Patients may be aware of their alters to varying degrees or be completely unaware of them. Patients with dissociative identity disorder generally experience symptoms such as memory loss, depersonalization, time loss. They may hear voices such as their alters conversing with each other. They may have somatic symptoms, and they may develop suicidality. However, generally, the alters help the individual to cope with and survive through their intense emotional memories. Dissociative identity disorder is extremely rare and extremely complex. However, it has many comorbid psychiatric disorders, and I have them listed here on the slide. And an underlying component of all of these other psychiatric disorders tends to be a higher risk associated with emotionally traumatic situations. We've discussed all of the disorders that I wanted to cover for this lecture. And as we went through the disorders, I mentioned some things about children with different disorders, specifically disorders such as dissociative identity disorder, such as social anxiety disorder. However, I want to go back and touch more on some other anxiety-related disorders in childhood. In general, anxiety-related disorders are among the most common psychiatric disorders in children and adolescents. And though they are the most common, they are still significantly underdiagnosed and undertreated in children and adolescents. Anxiety-related disorders are thought to have the dual genetic and environmental underlying cause. So while genetics can play a strong role in the development of many psychiatric disorders, remember the environment can often play a role. In children with anxiety-related disorders, we often see harsh parenting and underlying stressful life events. This is not me trying to stigmatize or say that all children with anxiety-related disorders have experienced harsh or poor parenting. Remember, there could be stressful events beyond the control of the family, as well as genetic predisposition at play if a child is presenting with an anxiety-related disorder. What is important, though, to remember is that in general, childhood anxiety disorders foreshadow the development of adult anxiety disorders. Most anxiety disorders of childhood are going to continue as a chronic disorder into adulthood. Aside from the disorders we've already talked about, I want to specifically briefly focus on obsessive compulsive disorder in pediatric patients as well as post-traumatic stress disorder in pediatric patients. So, it can sometimes be hard to differentiate between obsessive compulsive disorder and anxiety, especially in children. Like adults, children with obsessive compulsive disorder are going to demonstrate obsessions and compulsions. The key here with differentiating between anxiety disorder and obsessive compulsive disorder is the compulsions. The compulsions are the indicator of obsessive compulsive disorder because the compulsions, those ritualistic responses, are the specific effort to decrease the anxiety that differentiates anxiety from obsessive compulsive disorders. So the focus is on the compulsion. In children, obsessive compulsive disorder tends to be perpetuated by the need for perfectionism, by intolerance for uncertainty, or by an overestimation of threats. Children with obsessive compulsive disorders often have comorbid disorders of depression or ADHD. And finally, post-traumatic stress disorder in children. Pediatric post-traumatic stress disorder is very similar in symptomology to post-traumatic stress disorder of adults. Similar symptoms exist, such as nightmares, intrusive memories, and hypervigilance. Also, similar to adults who develop post-traumatic stress disorder, children who develop post-traumatic stress disorder are often survivors of abuse or have witnessed the abuse of a close family member or caretaker. So what is your role as the nurse when working with patients that have anxiety-related disorders? The first thing you need to do is assess the level of anxiety. You need to figure out where is that patient functioning at, because you're going to respond differently to someone that has mild anxiety versus is in a full-blown panic. So you really need to understand those 4 levels of anxiety. In general, as the anxiety increases, you need to decrease the stimulation of the environment. Keeping a calm milieu and environment is going to help with the individual's self-regulation. Remember, somebody with anxiety is trying to regulate their stress response. Don't make them have to regulate the environment as well. Assist individuals that have anxiety with coping in manners that are effective. Many of these individuals have been using defense mechanisms that may have worked for a time, may have gotten them through an acute phase, but now we need to help them develop some better longer-term coping mechanisms. And then maintain an accepting and helpful attitude towards the client. You want to demonstrate that you genuinely care about them, that you believe that these events are causing them this high-level anxiety, and that you do want to help them as they learn to process and work through these experiences. In contrast, do not refer to the client as crazy. Do not be judgmental of the client. Remember, many of these anxieties are anxiety that is out of proportion to the actual stressor or event. Do not be inconsistent. Do not act rigid. Do not be unpredictable, especially when dealing with disorders that are related to trauma and stress. Do not touch the client. If you need to do an assessment, verbalize what you are doing beforehand and ask to touch the client to listen to their heart sounds and lung sounds. Do not be critical of somebody's phobias. And if somebody has compulsions or rituals, do not take those away from that individual completely, as that can send them into the highest acute states of panic. And do not allow yourself to become a vicarious victim through somebody else's anxiety. Make sure you have your own self-care methods. We're now going to transition to discussing medications or psychopharmacology for treating anxiety disorders and related disorders. And in general, for these disorders, antidepressants are going to be our first line agent for treating the disorders. And this does make sense because many anxiety disorders have a comorbid diagnosis of depression. I do want to make a note here, very important, that when we are dealing with the rare but serious dissociative identity disorder, medication is not going to eliminate this disorder. However, if anxiety and or depression are present, we will still transition to antidepressants to try to help with those symptoms. So when you think anxiety disorders, I want you to think of antidepressants as the first line agent for treating these disorders, because anxiety disorders are chronic disorders. Therefore, we want to start with antidepressants and not benzodiazepines. Benzodiazepines, which we will discuss, can be used, but they should be used on a short-term basis when you need a quick-acting medication until your antidepressant can kick in. Because remember, antidepressants take, in general, 4 to 6 weeks to kick in. So you may need a benzodiazepine short-term, but that should not be the long-term treatment for anxiety-related disorders. We're going to discuss other anti-anxiety drugs besides antidepressants and benzodiazepines. And we're going to focus on buspirone, which can be very helpful in addressing cognitive symptoms of anxiety, such as worry, irritability, and apprehension. The nice thing about buspirone is that it is not as addictive as other drugs such as benzodiazepines. Buspirone, though, is usually a second-line drug. Remember, antidepressants are your first-line therapy. You would switch to buspirone for individuals that may not be able to tolerate the side effects of antidepressants or are not responsive to antidepressants. finally, we will discuss cognitive behavioral therapy. Though cognitive behavioral therapy is not a pharmacological agent, it is another important modality for treating and responding to anxiety-related disorders. In case I haven't hit on the stress response and anxiety enough already, as we head into medication, I wanted to do one more quick review of the autonomic nervous system, the fight or flight response, and anxiety. Beta agonists cause anxiety. Alpha-2 autoreceptors being underfunctioning causes anxiety. The brain produces too much norepinephrine, and that can be a trigger for anxiety. Therefore, drugs that are alpha agonists have anti-anxiety properties. So, the stress response, when an individual is having anxiety, they are having panic. Remember, we're going to see increases in epinephrine. We're going to see increases in norepinephrine, that fight or flight response. We're going to see increases in cortisol. We're going to see increases in plasma glucose. And we're going to see decreases in dopamine and decreases in serotonin. And that is underlying why these antidepressants work so well for anxiety. Another factor with anxiety is GABA. GABA binds to the adrenergic neurons in the brain and opens the chloride ion channels. When chloride is present, it slows neuronal firing. And when these GABA receptors are blocked, so that the chloride is not slowing the firing of epinephrine and norepinephrine, anxiety increases. So if we can increase your GABA, we can decrease your anxiety. Antidepressants, specifically SSRIs, selective serotonin reuptake inhibitors, are the first-line agents for treating anxiety spectrum disorders. And this is because of that comorbid connection between anxiety and depression, and because anxiety is often related to low levels of serotonin. So we want to boost that serotonin. Specifically, antidepressants are the most effective and safest prophylaxis for treating panic attacks and treating obsessive-compulsive disorder. And obsessive-compulsive disorder is considered to be the most difficult mental health disorder to treat. So we want to start with SSRIs. The other reason SSRIs are so effective for treating anxiety is that the serotonin, the increase in serotonin, upregulates GABA's transmission in the prefrontal cortex. And if you recall, I talked about post-traumatic stress disorder and the negative impacts on the prefrontal cortex. And on the last slide, I talked about GABA and the chloride channels, and that if we can increase GABA, we can upregulate the transmission of GABA, we can open up those chloride channels, we can slow the firing of the epinephrine and the norepinephrine and that stress response, and we can start to bring the anxiety symptoms back under control. Now, some of you may have heard or may have been prescribed an SNRI, a serotonin norepinephrine reuptake inhibitor for generalized anxiety. And you may be thinking, but we already have high levels of norepinephrine. There are only 2 SNRIs that are approved for anxiety. Notice I have this in yellow. Venlafaxine, which is Effexor, and duloxetine, which is Cymbalta, are the only SNRIs approved for the treatment of anxiety. These drugs, when used to treat anxiety, are going to be administered at much higher doses than you would see them administered for depression because of their increased reuptake. So, when you think for your exam about treating the meds you would expect someone to be on to be treating anxiety, SSRIs are your first line treatment, especially for panic and OCD. And the only SNRIs that would be approved would be venlafaxine and duloxetine. Benzodiazepines are not considered a first-line agent to treat anxiety, and they should not be used as first-line agents when treating anxiety spectrum disorders. However, you are going to see patients treated for anxiety-related disorders with benzodiazepines because benzodiazepines are extensively prescribed by non-psychiatric providers. If you recall from one of our very first lectures, the beginning of the semester, we talked about the fact that if patients do seek mental health treatment, they often seek treatment from their family provider and not from a psychiatric specialist. Family providers are familiar with benzodiazepines, thus they tend to prescribe them. However, we need to be aware that this is not best practice, and we need to be advocating for our patients to be on the most effective best practice medications. Now, that is not to say that benzodiazepines should never be prescribed. They should be prescribed in situations of time-limited treatment for a crisis or as an adjunct therapy until a longer-acting medication, such as an antidepressant, can take effect. Benzodiazepines should not be prescribed as a coping mechanism to respond to the stressors of everyday life. And benzodiazepines have absolutely zero therapeutic value when treating psychosis. So, how do benzodiazepines work? They enhance the effects of GABA. Therefore, they inhibit the anxiety response to stress, which is why they are effective for short-acting responses to immediate crisis. Furthermore, benzodiazepines depress the central nervous system, including the limbic system, the thalamus, the hypothalamus, and the reticular activating system. Thus, they, in response, do reduce anxiety, they promote sleep, and they produce amnesia through muting the incoming stimuli and evoking less of a response or reaction. A huge concern with benzodiazepines is that they produce dependence. In other words, the body functions normally when the drug is present, but functions abnormally once the drug is not present. Dependence on benzodiazepines can happen within a few weeks to months of regular use. Therefore, if individuals are on benzodiazepine therapy for more than 4 weeks, we need to provide an extensive taper period for them. And by extensive, I mean 3 to 6 months for a taper period. As I discussed in our lecture on substance use, withdrawal from benzodiazepines can cause various dangerous effects, including convulsions and seizures. So we want to make sure that we educate patients not to abruptly stop these medications. Also, as a bedside nurse, you need to be educating patients on the interactions between benzodiazepines and other substances, specifically other central nervous system depressants, such as alcohol, such as opioids, such as antihistamines. You also need to educate patients that benzodiazepines should not be used in conjunction with tricyclic antidepressants, MAOIs, antipsychotics, or grapefruit juice. There are lots of side effects to be concerned about with benzodiazepines. You also need to be aware that if an individual has overdosed on a benzodiazepine, that the antidote is flumazenil or romizicon. And that is the drug that is going to block the benzodiazepine binding site on the GABA receptor and selectively block the benzodiazepine receptors. What is important to know is that flumazenil has a very short duration of action. So once you give it, do not leave the patient alone. They may need a second dose or multiple doses as it works to eliminate the benzodiazepine from the system. And it may not reverse the respiratory depression and can further precipitate seizures. So stay bedside if you are giving flumazenil. I do not want you to get hung up on the nitty-gritty of this slide of the specific benzodiazepines. However, I felt like this lecture would be incomplete if I did not at least list some benzodiazepines for you. These should look familiar. They should be benzodiazepines that are on your drug card. You should be able to recognize these drugs as benzodiazepines. If there is something specific you need to know about this drug, it will be listed in bold. So, you should recognize chlorodiazepam oxide, Librium, as a benzo. You should recognize alprazolam, Xanax, lorazepam, Ativan as benzos. You should recognize midazolam, Versed as a benzo. These drugs, you may see any of them used as a short-acting response to crisis. However, I do want to point out that you are most likely going to see midazolam or Versed used to produce drowsiness and relieve anxiety before surgery. You will notice that is in bold. That's important. You should also know that midazolam puts patients at risk for cardiac arrest. So not only the central nervous system depressant, which is common across benzodiazepines, but we're concerned about monitoring for cardiac symptoms. Librium, you may see given for alcohol withdrawal, so you may recognize that drug from that lecture. Again, these nursing considerations are common across benzodiazepines, the CNS depression, the potential for addiction and tolerance. Xanax and Ativan, these are the ones you are going to see most common. A lot of patients with anxiety that are being treated by their family provider are going to be on Xanax or Ativan. These drugs may be prescribed PRN or as needed for acute crisis events. However, they should not be used on a regular basis to treat these disorders. I do have bolded for Xanax and Ativan that they are safer for older adults. They're safer than some of the other drugs. So if an older adult needs a benzodiazepine, you're going to want to look towards Xanax or Ativan, but even more specifically, most likely to Ativan because of its short half-life. Some special considerations with benzodiazepine. You need to be very cautious during pregnancy. Benzodiazepines have a risk of causing cleft lip and cleft palate during the entire pregnancy, so they should be avoided. They also can be passed into breast milk, so they should be avoided during lactation. However, as I mentioned, with benzodiazepines, older adults tend to do better on lorazepam because it has a short half-life. We want to avoid some of the other benzodiazepines because they do cause increased risks of falls. So older adults, we're going to want to focus on Ativan. So if you have an exam question about older adults and benzodiazepines, the choice that would be the best drug for the patient would be Ativan. I mentioned buspirone or Buspar on the intro slide for medications, and I noticed an inconsistency in our textbook that it says Buspar is a first-line agent for treating anxiety and a second-line agent. We are going to go with Buspar being a second-line agent for treating anxiety-related disorders. Antidepressants are our first-line response. If a patient does not respond well or does not tolerate the side effects of antidepressants, then we are going to move on to buspirone as our second-line agent for treating antidepressants. It is very important that I want you to understand buspirone is not a benzodiazepine. It does not bind to the benzodiazepine recognition sites. Buspirone works by decreasing the action of serotonin. So that is similar to how SSRIs respond. Buspirone has many advantages over benzodiazepines for treating anxiety. So really, we should be going to that before benzodiazepines unless we need that rapid response in a crisis. Buspirone is not sedating. It does not produce any type of euphoric high, so it has almost no abuse potential. It has no cross-tolerance with sedatives or alcohol, and it does not produce dependence, withdrawal, or tolerance. However, similar to antidepressants, it does have a delayed onset of 1 to 6 weeks. Therefore, if you are transitioning somebody from a benzo to buspirone, you do not want to stop the benzodiazepine immediately. Again, we should never stop a benzo immediately. We want a slow taper. Another nice thing about buspirone is that it does not depress the central nervous system. Other things you should be aware of. I have seen buspirone prescribed PRN. It should not be prescribed PRN. It has a delayed onset of 1 to 6 weeks, so it is not going to be effective as a PRN medication. That is something that you may need to do patient education on. So that's a little bit of an overview. So when you think buspirone, think second-line treatment if SSRIs are not working, and it has benefits of not being sedated, but it still has a delayed onset. Again, I don't want you to get bogged down in the nitty-gritty of these drugs, but I at least want you to see the names of the drugs on the slides of other drugs that may be used for anxiety spectrum disorders. Hydroxyzine, Vistaril, or Atarax. I see this drug all the time in the emergency department, that patients are on it for anxiety spectrum disorders. This drug is actually an antihistamine, so it can cause drowsiness, but it works because it blocks the reuptake of serotonin. You may see people on Lyrica, which is an anti-epileptic drug to treat anxiety spectrum disorders. This drug is similar to GABA, so it works on inhibiting the neuronal excitability the same way that GABA would, having those same anti-anxiety properties. Similarly, Keppra can be used as an anti-anxiety drug, even though it is an anti-epileptic, because it increases the release of GABA. And finally, you may see individuals on propranolol, Inderal, which is a beta blocker, especially those with social phobia, because the beta blocker interrupts the psychologic response of anxiety. So again, I just want you to be familiar that you may see these drugs and they would be appropriate secondary therapies to attempt, second-line therapies, if antidepressants were not effective in treating anxiety. I mentioned that I was going to discuss cognitive behavioral therapy. Cognitive behavioral therapy is considered a gold standard for treating anxiety disorders. Cognitive behavioral therapy is a therapy. It is not a drug. However, you will often see it used in conjunction with pharmacological treatments for anxiety, and it should be used in conjunction. Remember, these disorders are multidimensional. We don't want to just treat them with drugs. We want a combination of drugs and therapy. I know I've discussed cognitive behavioral therapy before, but as a brief reminder, it is that connection between how what you think, what you feel, and what you do all influence each other. So finally, let's wrap up this discussion of anxiety-related disorders. How are we going to manage the milieu? You are going to see clients with anxiety-related disorders in the milieu, whether they are inpatient for anxiety or rather if they are inpatient for a comorbid psychiatric diagnosis. So, when you are working with these patients, behavioral techniques are important. Cognitive behavioral therapy, helping them with behavioral management. Individuals with anxiety-related disorders generally benefit from group therapy and family therapy. They often benefit from physical activity and resistance exercises. So we want to keep the stimulation down, but remember, these individuals with anxiety tend to be restless. They need to move. They want to move. Sometimes teaching purposeful movement can help them with their symptoms of anxiety. Care should always be individualized. You need to base your care on the needs of that specific patient in that time. Safety is always your number one priority. Monitor for suicidal ideations and monitor for aggression.